Oral submucous fibrosis is a chronic, complex, potentially precancerous condition of the mouth characterized by juxtaepithelial inflammatory reaction and progressive fibrosis of the submucosal tissues. As the disease progresses, the jaws become rigid to the point that the person is unable to open the mouth. The condition is linked to oral cancers and is associated with cannot or betel quid chewing, a habit similar to tobacco chewing, is practiced predominantly in Southeast Asia and India, dating back thousands of years. History: in 1952, J. Schwartz coined the term atrophica idiopathica mucosa oris to describe an oral fibrosing disease he discovered in 5 Indian women from Kenya. S. G. Joshi subsequently coined the term oral submucous fibrosis for the condition in 1953. Classification: Oral submucous fibrosis is clinically divided into 3 stages: Stage 1, stomatitis; Stage 2, fibrosis, ALll lesions, blanching of the oral mucosa; ALll lesions, vertical and circular palpable fibrous bands in and around the mouth or lips, resulting in a mottled, marble-like appearance of the buccal mucosa. Stage 3, sequelae of oral submucous fibrosis, A. leukoplakia, B. speech and hearing deficits. Khanna and Andrade in 1995 developed a group classification system for the surgical management of trismus. Group I, earliest stage without mouth opening limitations with an interincisal distance of greater than 35 mm. Group II, patients with an interincisal distance of 26 to 35 mm. Group III, moderately advanced cases with an interincisal distance of 15 to 26 mm. Fibrotic bands are visible at the soft palate, anterior mandibular raphe and anterior pillars of forces are present. Group IVA, trismus is severe, with an interincisal distance of less than 15 mm and extensive fibrosis of all the oral mucosa. Group IVB, disease is most advanced, with premalignant and malignant changes throughout the mucosa. Pathogenesis: exposure to arecanut-containing products with or without tobacco is currently believed to lead to OSF in individuals with genetic, immunologic or nutritional predisposition to the disease. This hypersensitivity reaction results in a juxtaepithelial inflammation that leads to increased fibroblastic activity and decreased breakdown of fibers. The fibroblasts are phenotypically modified, and the fibers they form are more stable, produce thicker bundles that progressively become less elastic. Once the original loosely arranged fibrous tissue is replaced by the ongoing fibrosis, the movability of the oral tissues is reduced, there is loss of flexibility and reduced opening of the mouth. These collagen fibers are non-degradable and the phagocytic activity is minimized. According to a recent cross-sectional study, the time taken for return of salivary pH to baseline levels after chewing arecanut-containing mixtures is significantly longer in habitual users with OSF when compared to unaffected users. Symptoms: in the initial phase of the disease, the mucosa feels leathery with palpable fibrotic bands. In the advanced stage, the oral mucosa loses its resiliency and becomes blanched and stiff. The disease is believed to begin in the posterior part of the oral cavity and gradually spread outward. Other features of the disease include xerostomia, recurrent ulceration, pain in the ear or deafness, nasal intonation of voice, restriction of the movement of the soft palate, a bud-like shrunken uvula, thinning and stiffening of the lips, pigmentation of the oral mucosa, dryness of the mouth and burning sensation, decreased mouth opening and tongue protrusion. Causes: dried products such as palm masla and gutkha have higher concentrations of arecanut and appear to cause the disease. Other causes include immunological diseases, extreme climatic conditions, prolonged deficiency to iron and vitamins in the diet. Common sufferers: the incidence of the disease is higher in people from certain parts of the world including Southeast Asia, South Africa and the Middle East. Treatment: biopsy screening is mandatory before treatment. Treatment includes abstention from chewing arecanut and tobacco, minimizing consumption of spicy foods, including chilies, maintaining proper oral hygiene, supplementing the diet with foods rich in vitamins A, B complex, and C and iron, foregoing hot fluids like tea, coffee, foregoing alcohol, employing a dental surgeon to round off sharp teeth and extract third molars. Treatment also includes following the prescription of chewable pellets of hydrocortisone. 1 pellet to be chewed every 3 to 4 hours for 3 to 4 weeks, 0.5 ml intralesional injection hyaluronidase 1500 IU mixed in 1 ml of lignocaine into each buccal mucosa once a week for 4 weeks or more as per condition, 0.5 ml intralesional injection of hyaluronidase 1500 IU and 0.5 ml of injection hydrocortisone acetate 25 mg per milliliter in each buccal mucosa once a week, alternatively for 4 weeks or more as per condition. Submucosal injections of hydrocortisone 100 mg once or twice daily depending upon the severity of the disease for 2 to 3 weeks. Submucosal injections of human chorionic gonadotrophins 2 to 3 ml per sitting twice or thrice in a week for 3 to 4 weeks. Surgical treatment is recommended in cases of progressive fibrosis when interincisor distance becomes less than 2 cm. Pentoxifillin, amphetamine derivative that has vasodilating properties and increases mucosal vascularity, is also recommended as an adjunct therapy in the routine management of oral submucous fibrosis. IFN-gamma is antifibrotic cytokine which alters collagen synthesis and helps in OSF. Colchicine tablets 0.5 mg twice a day, lycopene, 16 mg a day helps in improvement of OSF. The treatment of patients with oral submucous fibrosis depends on the degree of clinical involvement. If the disease is detected at a very early stage, cessation of the habit is sufficient. Most patients with oral submucous fibrosis present with moderate to severe disease. Moderate to severe oral submucous fibrosis is irreversible. Medical treatment is symptomatic and predominantly aimed at improving mouth movements. Stem cell therapy for oral submucosal fibrosis. Recently scientists have proven that intralesional injection of autologous bone marrow stem cells is a safe and effective treatment modality in oral submucosal fibrosis. It has been shown autologous bone marrow stem cell injections induces angiogenesis in the area of lesion, which in turn decreases the extent of fibrosis, thereby leading to significant increase in mouth opening. See also, cutaneous condition. References. External links: Stem cell therapy for oral submucosal fibrosis in India, oral submucous fibrosis info, maxillofacialcenter.com, warrant.org, wrongdiagnosis.com.